Hello, everyone, and welcome to today's session titled Conversations with GIA, Housing as a Fundamental Component of Aging Well. Before we get started, I'd like to go over a few items so you know how to participate in this event. When you join today's webinar, you selected to join either by phone call or computer audio, and if for any reason you'd like to change that selection, you can do that just by accessing the audio pane in your control panel, and you can select a different option. You will have the opportunity to submit text questions to our presenters. And to do that, you just type your questions into the questions box of your control panel. You can send those questions in at any time. We are collecting them and we'll address them during the Q&A portion at the end. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. Welcome, John.
Thank you so much, Karina. And we want to welcome all of you. We have over 450 registered for today's webinar, so there's a great interest in this issue. And just to clarify, today we're actually talking about the issue of telehealth and telemedicine and its role in providing for older people with in the coronavirus environment. So I also want to thank, as always, the John A. Hartford Foundation for their support of today's webinar and all of our webinar series. Today we are discussing the use of technology to address social isolation among older adults. While this is not a new phenomenon, the COVID-19 pandemic has spurred great innovation and momentum in the field. As the demand for telehealth increases during the current pandemic, several changes have been made to telemedicine policy, coverage, and implementation to make it more widely accessible. These innovations and expansions come with many considerations and challenges. How can we address the disparities in internet access, digital literacy, and access to technology, particularly in rural areas? What will happen to telehealth once the pandemic ends? And how do we ensure that these supportive services are sustained beyond the current crisis? How are organizations that serve older adults expanding their services to adopt technology in their work? Today, we will talk about the current state of digital health and learn from organizations and experts who are using this technology to combat social isolation during this pandemic time. We are very pleased to be joined today by Steve Ewell, who is Executive Director of the Consumer Technology Association Foundation, Tom Camber, the Executive Director of Older Adults Technology Services, Alicia Frericks, who is the Vice President for Member Engagement at Lutheran Services in America, and Renee Quashie, who is the Vice President, Policy and Regulatory Affairs, Digital Health at the Consumer Technology Association. We are grateful for all of you for being with us. As was mentioned earlier, you will have a chance to enter your questions for our panelists at any time in the question box, which is on the right hand of your screen. I will be collecting these and reading them to our panelists during the Q&A portion. So now I would like to turn over the floor to Steve Ewell, the Executive Director of the Consumer Technology Association Foundation, for a short introduction. Steve?
Great. Thank you, John. Really pleased to be here. Thank you to you and to GIA for hosting this webinar on such an important topic. I'm really excited to have a chance to hear from two organizations that the CTA Foundation has been supporting and is doing some amazing work serving older adults, as well as one of my colleagues who's a real leader in the digital health policy space. And I know we're just going to learn a ton from all of the presenters today. Next slide, please. Very briefly, for those of you that don't know the CTA Foundation, we are an association foundation. We're affiliated with the Consumer Technology Association, which represents over 2,000 technology companies, and is probably best known for running CES, which is the global stage for innovation and happens each year bringing together technology innovators from around the world. Next slide, please. We launched our foundation in 2012 as a way to give back and specifically decided to focus in on serving older adults and people with disabilities as two growing yet underserved communities. And in particular, social isolation became one of the areas right from the beginning that we were looking at ways to address. Next slide, please. Over the time since we launched the foundation, we've given out over $4 million in grants to nonprofit organizations across the country, doing some really great work serving these communities. We see technology providing an opportunity to build connections, enable healthy and independent living, facilitate accessible work environments, and really, one of the items that often gets overlooked is creating opportunities for recreation and engagement. These problems and these opportunities also cut across communities, whether urban to suburban to rural. Each provide unique challenges to effectively reach. But we really believe in the innovation, whether it's coming from the industry, coming from the nonprofits serving these communities, or coming from the funders that are supporting this work and tackling these challenges across the country. Next slide, please. So one of the strengths of GIA is really the opportunity to meet and partner with other foundations working in the aging space. I would love to talk with other foundations that are participating on this call, following up with this and finding a way that we can all collaborate. So please join me as we hear from some great presenters and then have a great follow-up dialogue with your Q&A. And, I'd love to continue the conversation going on from here. But with that, I won't stand in the way of our presenters today, and I will turn it over to Tom Camber with Oates.
Excellent. Thank you very much, Steve. Hope everybody can hear me okay. I am very excited to be part of this webinar and be able to continue our long conversation that I've been having with Steve and the folks at CTA Foundation, and also at Grantmakers in Aging, about ways that we can harness technology to help people get online and get connected to their communities and families and to the culture and society around them, and also really change the way that we all think about aging together using technology. So I can go back to many years ago when we were first starting Oates, and I was fortunate enough to attend a GIA conference and hear some of the speakers and learn about the funding opportunities in the field. And as a nonprofit founder and executive director, have just really learned a lot from the various partners and supporters in the field. And then recently worked quite a lot with Steve, has attended CES for years, and been really fortunate to get support from them to develop some of our innovative programs at Oates, which I will describe in a moment. Next slide, please. So for those of you who are not familiar with Oates, we were founded, I'm here in New York City right now. We were founded here in Brooklyn in 2004 in Bedford-Stuyvesant. And the mission is to harness technology to change the way we age. Our first programs were started in collaboration with older adults themselves in terms of designing technology trainings that would be capable of bringing people from really a position of not having any engagement in many cases with tech up to a place where they could comfortably operate a device and function with the connectivity and stay safe. But more importantly, start thinking about ways to use those devices for the purposes of making the most of their older years. When we started out in 2004, I started asking people what they were interested in. We heard two different kinds of responses. First of all, people in many cases said, we're just, I've been sort of sitting on the sidelines of technology for years. I remember one older man saying, I was going to wait this out and I figured I would be dead by the time any of this became really necessary. And here I am still doing pretty well. And so I figure I've got to get out there and learn this stuff because it's not working. My original idea wasn't working. And he was joking with me about having lived too long, but in that case, it meant that he really needed to start learning things like what is a mouse and what is a keyboard and how do they fit together on a computer. But also the other kinds of things people really talked about were the value of using technology for a new approach to aging. And I heard it over and over again and have been for years, hearing seniors and people over the age of 60 saying, we are aging in a different way than our predecessor generations did. And older adults today are more productive. They are, in many cases, still working. They're entrepreneurs in very high percentages. They're civic anchors in their communities. They're volunteers. They're creative, active expression folks that are making art and music. And they're also managing their own health and finances and social connections in real time in a much more complex environment than people did before the technology revolution. And so we're hearing from people that they want to get online, but very quickly they're pivoting. It's kind of an interesting two-speed channel here, where on the one hand, people can really need very basic support and very basic engagement, but very quickly and sometimes simultaneously, they need to get access to a more expansive and ambitious set of opportunities to use the technology. OATS teaches on mainstream devices and applications. Our programs since the first day we operated have been free to end users, and we rely on folks like the people on this call to support our programs, as well as individual donations and earned income opportunities with partners around the country. So we're very involved in partnerships, and you'll hear some more about that. Next slide, please. In 2013, we launched the Senior Planet Center in Manhattan, and it was a really special moment for us because for the first 7 years of operation at OATS, we were really focused exclusively on supporting other institutions and other anchors in our community, particularly in New York City. And we didn't really have our own center, but eventually we realized it would be helpful to do that and to develop a program where people could come and see our strategy in person and see the entire package of offerings that we have. And so using stimulus money from the federal government, we were able to partner with the city of New York and in Manhattan launch Senior Planet, which was at the time the country's first technology-themed community center for older adults. And what made it special was that, first of all, we were able to brand it and strategize all of the interactions that we had with the customers and participants as a package. And so, for example, you'll notice it's not called the OATS Center. And people often said, well, why did you create this completely separate brand focused on the older adults? And what we were learning was that about half of our work at that time, and still probably the case today, was kind of a high concept, business to business, strategic and data driven set of interventions. And OATS as a corporate, nonprofit corporate structure was a really appropriate brand for that. And we could talk about our work in a way that was sort of, high concept and talked a lot about things like social return on investment and economic models of sustainability and impact. But on the other hand, when older adults went online and they came to the OATS website, they were kind of mystified by it. And we wanted a place where people could really connect with each other. So we created the Senior Planet brand. And in many cases, people know us today simply as Senior Planet. Most of the seniors who connect with our programs will go to seniorplanet.org and they'll get the information and start taking courses and programs there. So we use that framework at the center in Manhattan, and we applied a design thinking model to making sure that we could create a world-class experience for people that would come in and make sure that the training and support they got really engaged with them as kind of the progenitors of the next phase of their personal development. So we weren't really talking down to people or trying to force them into some kind of predetermined conception of what we thought they were there to do, but rather create a center that was an opportunity, that would be an environment where people could come in and bring their own priorities and pursue their own dreams there. That program served 1,500 people, I think, in the first year, and then it really took off and has anchored dozens of citywide programs in New York and now spread to 6 different states: Colorado, Texas, Maryland, California, Florida, and upstate New York. And the curriculum programming that we have there focuses on these 5 impact areas. So I always joke that I can't really tell you that of the 40,000 people that have been through the OATS programs, we don't really test them all on technology skills. So I couldn't honestly answer whether they can attach a file to an email or get their router up and operating properly from their living room. But I can tell you whether or not they're more mobile as a result of their fitness class, or whether or not they have more friends than they had when they started our social engagement class a month ago, or whether They are able to identify volunteer opportunities in their community, and whether or not their income and expenditures are more in alignment than they were before they started a financial management class. So OATS uses these 5 impact areas as benchmark opportunities to evaluate whether or not we're making a difference. And we survey people before and after all the courses to evaluate whether or not we're getting our mission advanced with the programming that we've designed. Next slide, please. When COVID happened, we were challenged with both a crisis and a little bit of an opportunity, because Senior Planet has always been partly digital. And we'd worked with Steve actually for several years on a project to create what we were calling a partner portal, which enabled us to digitally house a lot of our curriculum. We have 3,000 pages of curriculum, but for years we taught everything face-to-face, which of course is a sort of strange model when you're trying to get people to use technology and take advantage of it. So we worked with CTA Foundation on a couple of projects where we created a digital kind of repository for programs that we could spread around the country and help our different partner sites work with, called the Partner Portal. And at the same time, we also created a thing called Senior Planet U, which was a learning management system built in the Absorb LMS environment, where older adults who would take Senior Planet classes in person could also get a digital login. And so we were already, using a blended, what they call blended learning model, where people could get this hybrid of in-person and digital training and support. And when COVID occurred, we had been planning for years to enhance the digital side of that equation, with the idea that perhaps we could go fully digital with some of the classes. So it accelerated a strategic challenge that we had been working on for years, but it really gave the entire organization a wake-up call that we weren't really ready to do it immediately at the scale that we wanted to. And so very rapidly, we started converting all of our programs into lectures and online programming. And since March, we were able to convert to work with 40,000 participants. We've been delivering over 50 different programs per week. We've been partnering with major organizations like Zell and the City of New York and and Humana and other critical partners on this. And we've really been able to enhance and accelerate much of our programming through the online channel. So the number of participants that we've been working with has increased vastly. And in many cases, interestingly, our results have improved from the participant perspective. So we use a customer satisfaction survey score called the Net Promoter Score, which many of you may be familiar with as a popular tool in the corporate environment to evaluate whether or not people would recommend a program or a service to a friend or a relative. And what we have found is traditionally our Net Promoter Score is around an 82 to an 84 for our programs. But when we asked people after they took our online courses what their evaluation was in terms of customer satisfaction, the Net Promoter Score actually went up to a 94. And that's not what we would have predicted because of the digital challenge in terms of the interface and the grappling with the technology. But people really appreciated the opportunity to get social engagement and other kinds of content and support online. And our programming has actually increased in volume, and people seem to be really stuck with it and sticking with it and taking it on a day-to-day basis. Next slide, please. A couple of the major projects just to call out there. One major initiative that we embarked on that was from the last slide is a collaboration with the City of New York, where we're giving away tablets to seniors. The city has agreed, partly in consultation with OATS, to deliver 10,000 free Android tablets that are T-Mobile enabled to low-income residents in the public housing system here in New York. So the city is delivering the tablets, T-Mobile is providing the actual devices and the connectivity, and the city has contracted with OATS to provide pre-delivery support for the older adults who are going to be getting the tablets, and then ongoing phone-based and then ultimately computer-based training that can help them make the most out of the tablets and the connectivity that's being delivered. So on the one track, in terms of what we're doing after the COVID crisis, we've been working really hard to build up a call center that has the capacity to do thousands of calls per week, and we've been successful in doing that. One week we delivered 9,700 calls with a call center that hadn't existed just 2 weeks before, but we were able to reach out to the participants, prepare people for the delivery of the devices, assess their needs and their priorities, and then come back to them with trainings to get them set up on the tablets, where we were literally doing between 30 and 90-minute sessions with people over the phone to get set up with Gmail accounts and using the devices. And then on the other side of the equation, we've been looking more broadly to the number of disconnected older adults out there who are not part of the New York City, housing development giveaway here, but might be around the country and just not on connected to the internet. We've been delivering online courses on a rolling basis every single day, partnering with groups like AARP, or simply just using OATS content in various languages and different formats to provide best of class trainings for people. And that's required retooling all of our training delivery systems and models to get out there and help people get online successfully. So, people ask us sort of, what have we learned from this? And there's a couple of things that I highlight. One of them is, one of the big questions is, how do you handle the chicken or egg problem where you have first timers that are trying to learn how to use Zoom and use a device, but your channel to get to them and teach them is Zoom and the device. So, how can you get people to use something as a tool in order to learn the very first steps to be able to engage with it? And what we did was we started with that call center and we drove lots and lots of content with the call center so that people could really get engaged prior to the program launch, and use the good old telephone, which to us is a piece of technology that's incredibly powerful. It required a lot of support from our staff in terms of getting people trained properly to do those calls. But we've been doing, we started out with daily calls, and now we're doing weekly capacity building calls with our team and the partners. And we've been really successful in getting people to use those devices. The second challenge was, how do we overcome the digital screen? I mean, I use that term in a broad concept. It's a barrier to participation in many cases. And when we started doing our initial courses, I was observing them and found that people really, I didn't think the courses were ready for prime time, but we were delivering them anyways because people needed them. And so we retooled all of our content and moved away from programs that required a 10 or 20 session commitment from participants. And we also moved away from classes that went on for over an hour. And we shortened up the content. We actually split it into more digestible pieces. And then we retrained our staff to be more effective online. Help them think about, how do you handle things like your Zoom backgrounds and your multitasking challenges when you're on the internet? How do you pace the delivery of your content? And then how do you handle all the different things that are going on simultaneously with the chat that's going on, and the people that are coming into the session and need to be let in or handled if they're having a hard time? And it required a lot of organizational development challenges for us. And but ultimately, when the quality of programming hit a certain threshold, we found that our numbers started taking off, and about half of the people that were surveyed in the second month of our program said that they had never heard of Senior Planet, but found out through some kind of a link or online announcement, and then they just clicked on it and signed up for a class and came on. And a very high percentage of them seemed to be really satisfied and engaged with the programs, and then became repeat visitors. So now we're running classes that are having hundreds of people at a time, and even thousands. We did a course a couple of weeks ago, we had 11,000 people on a class that we did with ARP. And then finally, there's this question of, how do we handle the sort of continuity breaks of people? They're not coming to a session face-to-face for 5 weeks. So how do you maintain the dynamics there? And what we found was, if we keep the scheduling of classes regular over time and keep the staffing regular, so people get to know, for example, this guy Cass, who runs our morning stretch routines, people start to really develop a bit of a community within the sessions that's kind of unscripted, but seems like it's really working for people. We actually started beginning our courses a little early and ending them a little bit late, so that people could just chat on the Zoom calls. And in fact, what's been happening in some of the sessions is seniors will come on and say, hey, wasn't Marcy part of that program? And where is she today? And somebody should track her down and see if she's okay. And there's a sense of people really building a connection with each other, even through the Zoom format. Last slide, please. So this is a picture of an ancient Chrysler Sebring convertible, and I'm just gonna read you a quick email, because you're probably sitting there saying, why am I looking at this picture of a beat up old Chrysler? And this email came through last week from one of our participants, and I think it just kind of encapsulates a little bit of what we're doing here and why we're doing it. So It's from a woman named Marcia Lee, and it's addressed to our trainer, Jeanette, who works with Oates. And she said, I hope all is well with you and your family and you're having a great summer. I just finished an assignment as a poll worker for the Board of Elections and had been assigned work for all of the early voting days and the actual primary day. We used the iPad, and it reminded me of our class that I took, because without the class, I would not have been comfortable using an iPad. I've already been selected to work in the November presidential elections if it's not conducted by mail-in ballots due to the virus. Now, another milestone. With a portion of my earnings, I just bought a 1997 Chrysler Sebring convertible so that I can get to my pool club in New Jersey and be able to interact with people again, as no one wants to come into New York City in the summer. So Jeanette, a big shout out to Senior Planet for your help in getting me here. Many people are depressed because of the conditions today, but I am of a positive state of mind because with knowledge, all is possible to improve one's life. Best regards, Marcia Lee. I'll stop there.
Thank you, Tom. And at this point, we'll move on to our next speaker, Alicia. Alicia, are you with us?
Thank you. Can you hear me? Wonderful.
Yes.
Oh, wonderful. Sorry about that. It's good to have the opportunity to be here today and talk about how we are seeing technology address social isolation for older adults and caregivers in rural communities across the country. So pleased to have this opportunity and kind of shift our frame from New York City and the great work that was being done by Oates and talk to you about the impact of social isolation and how we're exploring using technology in rural communities, particularly in the upper Midwest. Next slide, please. Wonderful. So I am with Lutheran Services in America, and we're a national network of 300 members across the country. 200 of our members are in 1,400 communities and provide services for seniors ranging from everything from home and community-based services to residential care. And within that, we have established, I think it was in about 2017, a targeted focus on seniors aging in rural communities. And in partnership with several foundations across in the upper Midwest, we created the Great Plains Senior Services Collaborative, with really a focus on helping seniors living in the rural communities of Minnesota, Montana, and North Dakota age in the homes and communities of their choice, and really services to help support that. And as part of this, we've engaged a broad set of partners and investors in this collaborative. Since 2017, we've been able to bring $5 million through shared partnership investment into the program and services. We've served over 5,000 rural older adults and their family caregivers. And we've really established a broad array of community partners as well as provider organizations. And most recently, we partnered with CTAF to help bring some technology to some of our programs. So as part of this collaborative, we have a program called Remote Caregivers, and it really helps support seniors and their remote caregivers across the country. So next slide, please. Wonderful. So shift your frame a little bit and think about what is it like to age in the rural Midwest. And really, it's, I'm not sure how many folks on the phone are from the rural Midwest, but there are pockets that are incredibly remote, right? And if you think of the Great Plains Senior Services Collaborative and the 3-state area of focus, 87 counties in that 3-state focus are frontier counties, which means they have a population of 7 people or less. In North Dakota, there are 10 cities with a population of 7,000 or more. So, one of the things that this really means is that there's the challenge of remoteness is that there's limited access to healthcare. So if you think of back to North Dakota, there are 16 counties in North Dakota that have 0 primary care physicians, which really means about 42,000 individuals do not have a primary care physician in their county. So, imagine the challenges of, just access to healthcare. It's also interesting, and I think really critical to note that mental and behavioral health has been identified, by the majority of the critical access health hospitals as the most significant health issue, and that's really foundational to a lot of the other health challenges across the country and in rural communities, such as obesity and substance abuse and things like that. And so, we have a real opportunity to really think about how can we really focus on mental health and behavioral health to address that health crisis. The third kind of component of aging in the rural Midwest is, while America is graying, rural communities are graying at a faster rate. And so, you have the younger population leaving, and you have the older population staying. And so it just leads to, an infrastructure in communities that's rapidly shrinking. The healthcare systems is an example of that, but a lot of other community services. Just thinking of those challenges and looking at that was one of the reasons we kind of brought together the Great Plains Senior Services Collaborative. Next slide, please. So if you think about, the ecosystem that I just described, rural family caregivers play a key role in helping seniors age in place. And, we all know that all caregivers have challenges and bear significant financial and emotional stress, in addition to the joys and satisfactions of caregiving. But by definition, rural caregivers have unique challenges that are specific to living in these under-resourced communities. And in a survey by the National Caregiving Alliance and AARP, they found that, rural caregivers are most likely to be the primary caregiver, serve alone. So 60% of the rural caregivers serve as the primary caregiver, which is a significant increase if you look at that in more urban settings. And they perform caregiving activities for about 26.3 hours of care each week, which is significantly higher. They also have an increased difficulty in accessing and finding local services and supports for their the folks that they're caring for. So with 1 in 3 in that survey, caregivers reporting difficulty in finding local and affordable support. So there's a lack of information, and as you can imagine, COVID's changed a lot of that up too. But really being able to be connected to the supports within your community and find those is a key issue. The other thing is that rural caregivers, once again, by definition of limited resources in the community, are much more likely to actively assist with medical tasks. So as we have on the slide here, 62% report helping with medical and nursing tasks, such as, wound care and some of those, challenging activities. And so once again, if you sort of think about, well, it's kind of hard to go to the doctor or sort of, get the person I'm caring for into a medical setting, or even understand from the physician, am I doing this the right thing? It's just you're much more on your own there. And so what are the tools that we can do to help support those caregivers as they have those challenges? And then, as we've been talking, that the caregivers are more likely to neglect self-care and take care of themselves. And 1 in 10 shared that they had spoken with a healthcare provider about their own self-care. So really helping, looking at the caregiver, because we know that when the caregiver is able to take care of themselves, they're able to take care of the older adult that they're working with. I'd like to talk a little bit about the specifics in our program in the Great Plains Senior Services Collaborative. The average age of the caregiver is actually 66, taking care of someone who's an average about 82 years old. And the older adult who they're taking care of has an average of 4 comorbidities. So think COPD or diabetes or hypertension or those kind of things. And that 91% of the caregivers are related to the care recipient. So it's either maybe a sister or a wife or a daughter. And then 60% are female with an income of under $40,000. So, kind of setting the frame for the challenges and the environment that these caregivers are in. Next slide, please. So as part of the Great Plains Senior Services Collaborative, as I mentioned, we really have a focus on caregivers. And, really how can we help support caregivers who have limited access, as we talked about above, and what are the ways that we can do that? And so the program was piloted 3 years ago and has seen great success both in Minnesota and North Dakota. It uses basically the organization provides a caregiving coach, and so they provide coaching and teaching and encouragement to strengthen and amplify the role of the family or the informal caregiver. So they're a resource. So you can, call your caregiver and say, my dad, he's kind of, not looking so well today. If you've got a tablet, you can kind of show how he's walking. And so it can save you a drive to a doctor that may take 2 hours or so. So there's this ongoing coaching. Another kind of component of this is that the remote caregiver program also builds on an evidence-based model called Powerful Tools for Caregivers, which was really developed to support, it connects the senior, sort of almost like the OATS model, to remote classes and coaching. It has a section on self-care, managing emotions, self-confidence, and access to community resources. It also has sort of it creates a family, a community of other caregivers. So you kind of can connect with other caregivers in your community or across the state or whatever. And so, we've really seen that the program helps provide access to essential services such as buying groceries online or filling out a pharmacy prescription. And as part of this, what we've seen is, and through partnerships like with CTAF, is not everyone obviously has a tablet in their home. And so for those who need the access to a tablet, the program also provides participants with a tablet and a subscription to the broadband access. And in the Minnesota and North Dakota, the program serves about 103 seniors and their caregivers a month. The program has been well received. So as I mentioned at the beginning, we have a partnership with North Dakota State University. They are our evaluation partner in the Great Plains Senior Services Collaborative, and they're looking at self-reported health outcomes across the programs that we provide. And so they have helped develop a survey and really evaluate the impact of the remote caregiver program. And so what we have here is that 93% of the respondents reported that it helped reduce the stress of caregiving, that it helped them get some additional self-confidence, that they had a resource to go to, and really they didn't feel quite as alone, right? 87% had felt that their health had improved, their quality of life had improved, and while it's not the official Net Promoter Score, everyone who participates really recommends the program to others. So I think it really helps validate that feeling of connectedness. Next slide, please. Okay. So the COVID, when COVID came, we had this program, and then in the Great Plains Senior Services Collaborative. And then we also had some very high touch programs, and obviously those closed down immediately. And so what we were doing was looking to see how can we leverage the remote care program to provide other services and supports. And so almost overnight, we looked to see how we could expand the definition of caregiver. So is this a tool that maybe a formal caregiver could use, and things like that. And so one of the most telling things, though, is outside of the remote caregiver program, we had pretty much, when we moved to remote care in those other settings, pretty much 98% of those that care was delivered over the phone, because either the organization or the older adult did not have a tablet or access to the services. And so what we really see is a real need and a digital divide, right? Both, and I think it's important for funders to sort of think about this on this call as well. There's a need for older adults to have this technology, and there's also a need for a lot of the organizations, the community-based organizations, particularly in under-resourced communities, to have access to the, to the technology as well. And I think the other thing is, thinking through the impact of the services and how, what is the impact of these services going remote? And so we're starting to, I talked about the surveys and the partnership that we have with North Dakota State University is starting to really evaluate what was the impact, and as we continue, as we start to look to reopen, what do we want to keep doing remotely, and where do we want to bring back the physical and the in-person thing. And I think that the final thing is we need to remind ourselves that, a lot of what we do is about relationships. And while leveraging technology to enhance relationships can be really powerful, we don't want technology to be the excuse for us to avoid being in these communities and working directly with the people that need us most. And now I will hand it over to Renee Quashie.
Thank you. Next slide, please. And then the slide after that. The next slide. So I'm going to talk to you from a policy perspective, sort of what's going on in the agencies, what's going on Capitol Hill, because a lot's going on, and I think it impacts where telehealth is going to go in the shortened midterm, maybe not the long term, but certainly in the shortened midterm. So in order to understand the recent surge in telehealth use under the Medicare program, you first have to understand the importance of the Department of Health and Human Services public health emergencies. Because all the telehealth waivers and changes that have been established during the pandemic are directly tied to the duration of the public health emergency, and by extension, the President's emergency declaration. So to take a step back for a moment, this slide sort of goes through some of the timing of the public health emergency. The first one was issued effective January 27th, when the pandemic first hit the shores here in the United States. The public health emergency lasts for 90-day increments, and the Secretary of HHS just renewed the public health emergency effective July 25th, which takes us into late October. What that means is all the wonderful changes the Medicare program has facilitated get to stay at least until October. Next slide. The reason this is important is because what the public health emergency did was it allowed the Department of Health and Human Services to temporarily waive certain requirements and restrictions in the Medicare program, as well as some other public programs. And this is very important because prior to the pandemic, the Medicare fee-for-service telehealth benefit was very limited. And there were a number of reasons for this. Number one, beneficiaries had to be in a county outside a so-called metropolitan statistical area or in a rural health professionals shortage area in a rural census tract. So in other words, the program was really designed for the folks living in rural areas in the United States. Two, the patient had to physically present at one of 8 kinds of facilities like a hospital or physician's office. What's important to note there is the home was not an approved site, meaning that if a beneficiary was at home when receiving telemedicine services, those would not be covered under the Medicare fee-for-service program. 3, only 8 kinds of providers could furnish services, or anything outside the 8, and the 8 of the usual suspect: physicians, registered nurses, clinical psychologists. But anybody outside of the 8 professional types was not covered. And then finally, only a limited number of services were actually covered and reimbursed under the Medicare program. So assuming you met all the other requirements, only certain services were covered. With the public health emergency and all the waivers, all that has changed. Next slide, please. Again, this is just a reminder that the reason we're talking about the public health emergency is because the waivers and the changes are directly tied to the public health emergency. So those waivers and changes expire the second the public health emergency ends. Next slide, please. In this slide, I'm just showing you that a lot of the changes took place over time. I give kudos to this administration for unleashing the full power of digital health, particularly telehealth and remote patient monitoring by the blanket waivers, the interim final rules they issued, the regulatory waivers that came in bits and pieces. Congress also stepped in the CARES Act. It's been a really coordinated effort. It's been coherent. And as we're going to see in a second, it's really facilitated a huge surge in the use of telehealth. Next slide, please. So what has changed? So number one, what the waivers and changes during this pandemic have done is they've removed the geographic and facility requirements. As I said about 2 minutes ago, the telehealth benefit under Medicare is really geared for rural Americans. And remember, you have to present at a particular facility in order to receive services. Those requirements and restrictions are gone. So it doesn't matter what part of the country the beneficiary happens to live in, those services will be covered. And the patient can be at home and still receive services, so they don't have to physically go to a clinical facility to receive telehealth services. That was huge. The types of professionals who could provide telehealth was expanded to include certain kinds of therapists, like physical therapists. Remember, we talked about the limited number of services that were covered. Medicare expanded those services to include 80 new kinds of codes. They allowed direct supervision to occur by real-time audio as opposed to physical presence. For certain kinds of services, phone-only services have been covered as well. Next slide, please. In addition to that, they also made it easier for Medicare beneficiaries to receive telehealth services by very common kinds of applications. And the slide goes through this here. WhatsApp, Apple FaceTime, Facebook Messenger, those kinds of pathways that originally were sort of in a gray area as to whether or not they were permitted. And so under the waiver, one of the waivers that was issued, they really sort of relaxed some of the requirements and restrictions around what kinds of solutions could be used for telehealth services. Next slide, please. So the result has been a phenomenal expansion of telehealth use. And I'm going to go through a few statistics because I think they really clarify what has occurred over the last 5 months or so. So Medicare issued, actually, the Department of Health and Human Services issued a report that came out 2 days ago that really goes through all these stats. Here's some takeaways from that. So nearly half of Medicare primary visits were provided via telehealth in April. Why is that important? Because in February, right before all these waivers came in place, less than 1/10% of primary care services were done via telehealth. In other words, the telehealth benefit was really almost never used. A lot of it had to do with the restrictions that we talked about earlier, but it was a very underutilized element of the Medicare program. So even though half used telehealth for primary care visits in April, that has sort of leveled off somewhat, but it's leveled off at a far higher place than it was pre-pandemic. The other thing too is we've seen greater increases in telehealth use in urban than rural areas. The other thing that sort of brings this into great relief is what the slide talks about here. 13,000 beneficiaries a week were receiving telemedicine services prior to the pandemic. In the last week of April was 1.7 million for a total of 9 million by mid-June. So you're talking about an explosive surge in the use of telehealth. Next slide, please. The other thing to note is that those in the Northeast have tended to use telehealth more than folks in other parts of the country. I think this is likely due to the fact that the Northeast was the first region to be seriously hit by COVID-19, and therefore were more ready and apt to use telemedicine services for triaging and assessment during this pandemic. Next slide, please. And I think here's the biggest takeaway, and I think a couple of the panelists have sort of spoken to this, which is folks over the age of 65 are far more comfortable receiving services via telehealth than people have assumed. I think this has been an eye-opener for Medicare officials, and you can see the statistics there. I think in my dealings with the Department of Health and Human Services and with folks on Capitol Hill, there's always this sense, this assumption, especially among telehealth doubters, that seniors would simply not use or be comfortable using technology to receive healthcare services. But what we're finding out during this pandemic with all the waivers and changes is that that is not true. And that if it's well presented, if it's easy to use, seniors are willing and able to use these services. And the other thing we're finding out is when people actually use telemedicine services, patient satisfaction rates are through the roof. Next slide, please. So with all this surge in telehealth use, what is going to happen? Because as I said before, the waivers and the changes that we've seen over the last few months are only tied and only valid through the public health emergency. Once that public health emergency ends, so do these waivers, and we go back to the highly restrictive Medicare benefit prior to the pandemic. And I think this is striking a lot of people as problematic. And we've heard even from CMS administrator, CMS meaning the Centers for Medicare and Medicaid Services, the agency that runs the Medicare program. That agency's administrator basically said the genie's out of the bottle, we can't put it back. But what does that look like? So we've seen some efforts on Capitol Hill. For example, in the recent Senate Republican COVID bill, legislators are proposing to extend the telehealth waivers through 2021 or the end of the public health emergency, whichever is later. They're essentially buying time so that folks can actually study cost and outcomes data. And that's one approach. There are other approaches on Capitol Hill we've seen. So for example, the aptly named Protecting Access to Post-COVID-19 Telehealth Act was introduced a couple of weeks ago in the House. It's a bipartisan effort. And what that bill would do is it would make many of the telehealth waivers we've talked about, particularly those regarding geography and the patient's home being an approved originating site, would make those waivers permanent. So we would not go back to the very restrictive geographical and originating site restrictions we saw pre-pandemic. It also includes some other provisions that make it easier for telehealth services to be delivered. But having said that, there is quite a bit of skepticism regarding the efficacy of telehealth in Congress. Some favor cost and outcomes data studies before making any of the telehealth waivers permanent. So we'll see what happens there. And I'll leave you with this. I think the other thing we've seen during the surge is that a lot of clinicians are realizing that providing services this way, particularly certain kinds of services, is actually incredibly efficient and very effective. And so what this period has done is really facilitated the use of telehealth by providers who otherwise would never have gone near it. And so I think for the future, that bodes very well. And I'll end there for some Q&A. Appreciate your time.
Well, thanks very much. We've had so much great content from our speakers today. We're approaching the end of our hour. I would like to go back, however, and ask each of our panelists, as well as Steve Ewell, to tell us a little bit about what they want to leave the audience with today as we end up our hour. So, Steve, could we talk with you for a second? So, what are your final words of wisdom for our audience today?
Sure. Thank you, John. I think we've heard some really exciting models that are being used both by OATS, by Lutheran Services, and then being able to hear that perspective on what does the telehealth system look like now and some of the challenges going forward. I think this is a great opportunity for the GIA members to approach these issues, to have conversations about these issues, and really, ultimately what we're trying to do is, serve the communities that we're trying to support. So I really look forward to continuing this conversation with GIA.
Thanks, Steve. Let's turn then to Tom. Tom, what are your final words of wisdom for the group?
I guess my big takeaway, and I'm coming a little bit off of what Renee was talking about, is just the sense that there's a real opportunity here in promoting some of the community level nonprofit voices and connecting the organizations that have cultural competency and local, almost sort of specialized knowledge about certain sectors of the older adult population and also certain kinds of particular activities that people are engaging in, such as telehealth. There's a real opportunity here to promote some of the really innovative ideas that people have. I think the lessons that we're learning at Oates right now are related to the notion that for a long time we've been saying that older people want to get online, they want to use the technology, they'd like to be able to get online from home, they want to work from home, they want to get more advanced, more progressive services that are more in keeping with their expectations for their personal development and their desire to improve their communities. But sometimes the government agencies particularly and some of the policy environment has been a little slow to catch up to what seniors themselves are asking for and what some of the community-based organizations are really pushing for. So some of the most successful things that we've worked on in the last few years seem to find a connection between the nonprofit activists who are often trying to push the envelope and some of the larger institutional partners like a Humana or an AARP or a CTA foundation in this case, who are helping people really connect to a bigger market, a bigger opportunity. So I would suggest just keeping to kind of look for the innovations on the ground level and promote those ideas, because in many cases, as we're learning with something like telehealth, people are ready for change. We just need to get stuff activated and get people implementing some of these new programs to show their value.
Thanks so much, Tom. Alicia, how about for you?
Yeah, I would just build on what Tom said. And, I think it's definitely an opportunity and there's a strong desire, but also, the digital divide is real and that there's capacity on all levels and through partnerships, I think, and really focusing on those pieces, I think will be important as we look forward.
Thank you a lot. Renee?
Yeah, I think for me, what has become clear is how much of clinical practice actually follows reimbursement, coverage, and policy. And I think what we're seeing with this pandemic, particularly from the Medicare perspective, is that, as Tom says, there's a great willingness for people to use these kinds of services. The question has always been, how do you get people to actually use these services? Once they use it, as I indicated in my chat, patient satisfaction rates are very high. So I think we are at a precipice. This is a tremendous opportunity to perhaps refashion the way we deliver services, the inclusion of technology in order to connect clinicians and patients in a more effective way, meet and deliver services where patients are. And I think we have a tremendous opportunity to do that because as Medicare goes, so do other payers. And so I'm hopeful that at least over the next couple of years that we're going to continue to see the increase in the use of technology in the delivery of healthcare.
Well, thank you so much. I want to thank Steve Ewell, Tom Camber, Alicia Frericks, and Renee Quashie for being with us today and providing their tremendous expertise in many different related areas around this topic that we were discussing today. I also want to thank the John A. Hartford Foundation for their continuing support of today's webinar and our webinar series. We will be making today's presentation available to anyone who wishes to view it for free, including both the slides and the audio. They will watch for an email to be sent to you within the next few days. And we would ask you to help us to let other people who might have an interest know about this. As I said, these are available free of charge to anyone who wishes to hear them. We will be sending you information about our next Conversations with GIA webinar quite shortly. And finally, I want to thank all of you for participating in today's webinar. Please stay safe.